Good morning. Thanks so much to everyone for joining us. My name is Yao Liu, and I'm a glaucoma specialist here at the University of Wisconsin, the United States. I'm looking forward to sharing with you some pearls about minimally invasive glaucoma surgery and some of the unexpected things that unfortunately can happen anytime we're doing surgery. All right, so we'll begin today with talking about, how we ended up becoming so interested in minimally invasive glaucoma surgery. Then we'll talk about the many, many different types of minimally invasive glaucoma surgery and some of the complications that you may run into once you start doing these types of cases. Just to kind of give people a flavor of what has happened in the glaucoma world, this is going back to, my childhood. You can kind of imagine back in the day when we first started with the original Nintendo, being a glaucoma specialist sometimes feels like you're a bit of an eye plumber. And it was a pretty simple back then. There weren't too many options. We had trabeculectomy, we had tube shunts, it was pretty much, those are sort of the bread and butter still today. But as you know, with the advent of minimally invasive glaucoma surgeries, things have gotten a little bit more complicated. So now it almost feels like the number of options that are available to treat glaucoma feels sort of overwhelming. This is sort of a way that I like to think about glaucoma surgical options. And what you see here is a list of many, many different types of both minimally invasive and more traditional glaucoma surgeries. And you can think of them as being on a continuum, meaning that some of these minimally invasive glaucoma surgeries, for example, they're less risky, but they're also less reward. So if you put in something like an eye stent or do a Cahook dual blade goniotomy, you're going to get perhaps a little bit of pressure lowering, maybe get the patient off of one or two medications, but it would be unusual to have a significant drop in pressure. Now, anything's possible, especially for patients who have narrow angles where perhaps the cataract is playing more of a role in their elevated pressures. But in general, you can think of how you want to match the risk of the glaucoma surgery and the need for pressure lowering to the needs of the patient. One of the questions that was submitted prior to the webinar was, what would you start with when you're first trying to learn minimally invasive glaucoma surgery? And based on this list here, you can see that at the top being the lower risk procedures probably would be something like the eye stent or the Cahook dual blade. The best way to start learning, I would say, is when you're doing cataract surgery, even in patients who are not scheduled for glaucoma surgery, you can practice doing intraoperative gonioscopy, where you have them turn their head, get a Swan-Jacob gonio prism, and just look at the angle. You're not doing any procedure. You can take a Helon viscoelastic cannula and basically kind of practice the motions that you would make for a glaucoma procedure without doing a glaucoma procedure and have them turn back. And so just getting used to intraoperative gonioscopy, getting a beautiful view. Really, the view is everything. You want it to look like a textbook every time. That's going to give you the biggest success. So when we look at this continuum, I would say the lower risk procedures are at the top here. Those are usually the easier ones to start with. Once you get to patients who need a little bit more pressure lowering, they get a little bit more complex. So you see this middle group here, and we're going to walk through each of these one by one. I should also say that it's very unusual for any surgeon to do all of these surgeries. It's first of all, it's possible to train in all of them, that's for sure. It would be unusual to be doing a large volume of these, enough that you would be doing all of them on a regular basis. So most of us choose, your favorite types of the minimally invasive glaucoma surgeries. So don't feel that you need to be doing all of these, but rather that you just need to be able to choose the ones that are most effective for you and your hands, as well as meet the needs of your patients. Then you can see at the bottom, the more traditional glaucoma surgeries, tube shunts, trabeculectomy, and transscleral cyclophotocoagulation. So Those are sort of our tried and true methods, but the ones that are listed in yellow are typically considered what we would call minimally invasive glaucoma surgeries. You'll notice that I group several of them, the Zen gel stent, PreserFlow, and Express shunt, really together with the more traditional surgeries, and that's because most of them rely on a mechanism that is relatively similar to a trabeculectomy. As you can imagine, the risks become greater once you go down that path. All right, so we're going to start with our poll question number 1 and get a sense for the group here. What is your personal experience with minimally invasive glaucoma surgery? And the options are A, you've never performed these procedures. B, you have performed maybe a few procedures. C would be you perform these procedures just a few times a year. And D would be that you perform these procedures at least once a month or more often. All right, so you can see that the majority, 70% of you, have never performed these procedures. So this is a very new experience for you. It looks like a few have performed a few procedures, about 15%. And then a relatively small number, less than 10%, have performed these procedures a few times a year, and then a few do these procedures once a month or more. So it looks like the majority of people have never done minimally invasive glaucoma surgery. So I will tailor the talk for that group here. All right, so I also, I guess this is really directed to the people who have done minimally invasive glaucoma surgery. So this poll question asks, which type of surgery do you perform the most? The options are grouped. The first option would be angle-based procedures such as iStent or Cahook, Hydrus, GAT, Omni, or canaloplasty. The second group would be ciliary body laser procedures like endocyclophotocoagulation or micropulse. The next group are things like the gel stent or express shunt or PreserFlow. The next group would be any other type of procedure that I didn't list here. And then, of course, not applicable for those who don't perform these procedures. So we'll give people a few seconds to respond to this poll so we can see what type of experience those of you who've done minimally invasive glaucoma surgery have had. So as again, most people have not done any of these procedures, but it looks like the majority have some experience who have some experience have done angle-based procedures. And just like we talked about earlier, those are often some of the easier ones to start with, as well as the ciliary body laser. So great. Thank you for answering those poll questions. All right, so let's get to how did we get here? Why is there so much interest in minimally invasive glaucoma surgeries? Well, for those of you who've ever done a trabeculectomy or any other, or tube shunt, you know that it can be very humbling. These are just some examples of patients who had blood leaks, endophthalmitis. You can see they're Seidel positive, and these can be pretty devastating complications, and it makes it very humbling, as I said, to be a glaucoma surgeon. And then this is just some further information about blood leaks. Anytime you have a blood leak, which has become more common with the routine use of mitomycin C with trabeculectomy, you can have a significant risk of infection. It actually confers a 10 to 25-fold increased odds of having phlebitis or endophthalmitis. Unfortunately, in patients who have recurrent infection in the setting of a blood leak, that about a quarter of them will have a visual outcome that's pretty poor, worse than 2400. So these are some of the most dreaded complications of glaucoma surgery. They often can occur very late. So this is many years after the initial surgery when the blood has become cystic and thin. And so this has led us to really try to pursue alternative options for glaucoma surgery. This is one of the studies that came out more recently, the primary tube versus trabeculectomy study. And at 5 years, they looked at the outcomes of 242 eyes of 242 patients. These patients, unlike the prior tube versus trabeculectomy or TVT study, had no prior incisional eye surgery. And it was really designed to answer the question, what is the best initial glaucoma surgery for people needing a tube or a trab? And so what they found was that it was relatively equivalent in terms of the difference in pressure or glaucoma medication usage. but there's a pretty high cumulative probability of failure. So you can see about a third of patients were not able to achieve the target pressure or had significant hypotony or needed reoperation or had significant vision loss. So these are not very positive statistics when you think about doing this type of surgery. These are also just some of the emotional reactions that we often have as glaucoma specialists. So these are just some examples of talks at the 2019 American Glaucoma Society meeting. So you can see one of the first ones listed here was tubes or trabs, love or hate, they are here to stay. And the next one here was, doctor, why did I go blind? How I wish I had done the surgery. And that was followed by, doctor, please remove this thing from my eye. How I wish I had not done this surgery. And that, unfortunately, is some of the feedback that we get as glaucoma surgeons. Here are some of the challenges, however, even with minimally invasive glaucoma surgery. So you can see later on the program, avoiding maximally annoying complications with minimally invasive glaucoma surgery, as well as with inflow ablative procedures, which are targeting the ciliary body, and also, again, maximally annoying complications of subconjunctival procedures. So there's no perfect glaucoma surgery, but I think we can try to best match, as I said earlier, the needs of our patient to the risk-benefit profile of the surgery that we pick. All right, so let's talk about the individual options for minimally invasive glaucoma surgery. So this is the original iStent. This is one of the earliest minimally invasive glaucoma surgeries. It's been around over 10 years. And you can see that it's placed in the angle using intraoperative gonioscopy. And as I mentioned earlier, this is something that people can practice on a routine cataract patient by having the patient turn their head using a Swan-Jacob gonio prism and using some sort of viscoelastic cannula. You're not doing any procedure, but you can practice getting the positioning of the patient so that you have a beautiful view and feel comfortable manipulating an instrument in the eye with the intraoperative gonioscopy. I would say that is the #1 key to being successful, is having a good visualization. If you feel like the view is so good that you could publish it in a textbook, that's about the level of visualization that you would want to have. So the current version of the iStent is the iStent Inject W. There also comes in a version called the iStent Infinite. The only difference is that the iStent Infinite allows you an infinite number of clicks or opportunities to basically release the implant, whereas the prior versions had a limited number of clicks. And the iStent Infinite is also approved for use in the US aside from cataract surgery, whereas the iStent Inject W requires doing cataract surgery at the same time. So the nice thing about the iStent is that it's very compact. It's a very small implant, and it's basically just tenting the tissue a little bit by applying pressure and pushing the button. You'll hear a click and it'll deploy. And so it's a relatively one of the relatively easier ways to start learning to do minimally invasive glaucoma surgery. There's also been studies that show a dose-dependent effect, meaning that the more stents you place, the more effect you get. And so in places where you are not limited by reimbursement, it's certainly possible to put many more iStents than what we currently do in the US, which is usually 2 or 3. And we know that that can have a greater effect. There's still a lot of debate in the community as to what are the optimal positions for the locations of the implants, but there's still a lot of research being done to try to figure out how we can maximize the effectiveness of the positioning. All right, so let's talk about a few cases where the iStent was and perhaps was not quite as effective. So this is our first case. This is a 70-year-old woman with moderate primary open-angle glaucoma. The iStent in the US is approved for mild to moderate open-angle glaucoma. And so here's kind of a typical patient. So this patient has stable glaucoma. The visual fields have been stable. She's only taking on one medication, latanoprost, at bedtime. And prior to surgery, her pressure was already at target in the mid to high teens, but she had a visually significant cataract. So in this case, we can do combined cataract surgery and an eye stent implantation. And after the surgery, her pressure remained at target on no medications. So we were able to basically substitute the latanoprost with the eye stent, really improving this patient's quality of life. I think it's really important to recognize that medications have a pretty significant burden on quality of life. And I have so many patients who you would think, being on one medication like latanoprost wouldn't have significant side effects. And talking to them after surgery, once they're off of that one medication, how much happier they are, not only in terms of not having to remember to use the medication and get it refilled and pay for it, but also just the ocular surface is much more comfortable. They feel that they're seeing better. Their eyes feel better. They're less irritated. It can be quite dramatic. So don't discount the importance of getting your patients off of even just one medication. All right, so before we get into some of the complications, I'd like to ask the group, this is our poll question number 3, have you ever seen a serious complication from minimally invasive glaucoma surgery? So your options are either no, or yes, you have seen a serious complication, but the patient had a good outcome. The next option is yes, but the patient had a good outcome only after traditional glaucoma surgery is performed. And finally, yes, you did see a serious complication, and unfortunately, the patient suffered permanent vision loss. So we'll give people a few seconds here to select these options. I realize that most people don't do minimally invasive glaucoma surgery here, but I'm sure you have seen some of the outcomes from colleagues and other folks. All right, so it looks like about half of people have never seen a serious complication. The good news is that the 30% of you who have seen a complication, but the patient had a good outcome. So the majority have either not seen a serious complication, or when it did happen, the patient had a good outcome. And then it's very relatively uncommon that the patient had suffered permanent vision loss. But sometimes it looks like about 14% of you have seen a patient who ended up needing traditional glaucoma surgery. Great. Thank you for answering that poll question. It should also be noted that minimally invasive glaucoma surgery can be seen as a bridge to traditional glaucoma surgery. So for example, you might think this patient, might benefit from doing a trabeculectomy, but perhaps they're very reluctant to have a bigger glaucoma surgery. And so sometimes using a stepwise approach, you can try doing a minimally invasive glaucoma surgery first, build some trust with the patient. They might not get as much lowering as you were hoping for because the minimally invasive glaucoma surgery is not as effective as the trab in lowering pressure. But then if they do need the trab afterwards, you can feel better that you did provide them with a less risky option initially. So it doesn't have to be either minimally invasive glaucoma surgery or traditional glaucoma surgery. You can do the minimally invasive glaucoma surgery as an initial step. If it works and the patient doesn't need further surgical treatment, that's great, but they may still require additional surgery. And so that's something to discuss with each patient as well. All right, so now it's time to get to something a little scarier. So this is our second case. This is a case where things did not really go very well, and I'll be returning to this case at the end to kind of talk about what happened to this patient. So this is just the beginning. So this was a 90-year-old man with one good eye. He's monocular. This good eye had moderate primary open-angle glaucoma. Notably, he was not on any sort of blood thinners or anticoagulation. So that's something to keep in mind is anytime you're doing angle-based surgery, you want to be careful about patients who are anticoagulated just because their risk of bleeding is higher. So this patient was consented for combined eye stent with cataract surgery because he had a visually significant cataract, and like our last case, his glaucoma was well controlled on just one medication, and his angles were open on gonioscopy. So let's see the video here. So this is the original eye stent injector. And we're using the clear corneal incision. The cataract surgery has already been done. You can see the eye wall is in great position. And so here the surgeon is just touching the trabecular meshwork, and you're seeing something unusual already is that every time the instrument touches the trabecular meshwork, you're getting quite a bit of heme, which is not typical. An attempt is made to pass the stent. It's not successful. The stent is not in good position, and so it needs to be retrieved. So then, because the view has gotten so poor, the surgeon now goes in with the IA probe to try to clear some of the blood. So anytime your view gets poor, you can either inject viscoelastic or use INA to remove some of the heme to improve the view. Okay, so INA was done, viscoelastic was attempted to be injected. You can see this is, again, not what you want to see, which is that there's just heme coming out of the angle by itself, even with viscoelastic keeping the eye inflated. So these are signs that probably the surgeon should have stopped at this point. However, they decided to continue, and here they are making another attempt to insert the eye stent. Okay. And so you can see now that even in this eye that's filled with viscoelastic, there's now heme that's actually really just coming out of the main incision, and that's starting to grow and grow. So that's a pretty bad sign. The surgeon attempts to inject more viscoelastic, but all that does is liberate more heme. So the heme is just now spurting out of the main wound as well as any of the paracentesis sites that the surgeon is attempting to inject viscoelastic to try to tampen out the heme. So this is not typical. Fortunately, this is pretty unusual, but just shows that you can get into kind of a bind here. You can see how much bright red blood there is. It's just coming out of the eye very rapidly anytime the surgeon attempts to inject viscoelastic. So we will get back to what happens in this case at the end, but suffice to say this was not the intended outcome, especially in a patient who this is their only seeing eye. All right, so let's talk about some other possible complications and types of minimally invasive glaucoma surgery. So this is the CyPass microstent. It was voluntarily withdrawn from the market. It was a suprachoroidal stent, and that was because doing post-market surveillance, they found that there was significant corneal endothelial cell loss at 5 years. So this was also something that was implanted using intraoperative gonioscopy. It was quite popular for a while and is no longer used. For people who see these patients now, those who have a very long segment inside the anterior chamber, there are ways to trim that in order to minimize the amount of corneal endothelial cell loss. So the next angle-based procedure I'll talk about is called the Hydrus microstent. And so this is a relatively large stent. And because it is large, it does have a greater pressure lowering effect compared to the eye stent. And so the main benefit is that you can get you can get much more significant pressure lowering. Still, obviously not at the level of a trabeculectomy, but if you feel that you need something a little bit more than the eye stent, this can be a good option. It is more difficult to learn just because it is a larger implant. Another procedure that was more popular 10 years ago has become less popular these days is an ab externo canaloplasty using a fiber optic cable. This one, the eye tract catheter can be used ab externo. I'll talk about using it ab interno shortly, but it goes around Schlemm's canal. In these cases, people use a double flap, just like you would for trabeculectomy. You have to find Schlemm's canal, which can be pretty challenging from the ab externo side. You then thread a catheter where you have attached a 9-O-proline and basically tie the 9-O-proline all the way around to essentially cinch the eye and open up Schlemm's canal. So this has become less popular, as you'll see with some of these other angle-based options, because it is not conjunctivally sparing. It's a pretty difficult technique to use, but it can be pretty effective in certain patients. Here, I would say the Cahook dual blade is another one of the easier, minimally invasive surgeries to learn. In this procedure, we remove a section of the trabecular meshwork. The nice things are there's no implant. However, you're pretty much very likely to have some postoperative microhyphema at least. We typically avoid doing this in anticoagulated patients just because there can be a lot of bleeding afterwards in those patients. What you're seeing in this picture is the sort of open strip of meshwork that is now open after applying this to the nasal trabecular meshwork. So I'm seeing a question in the chat about encountering significant hyphema with Cahook. I would say it's pretty uncommon, but that's also because of patient selection. So I purposely avoid patients like the 9-year-old patient with who's monocular previously, like in that other case, as well as people who are on anticoagulation. So it's pretty uncommon. As I mentioned earlier, in the iStent case where there was significant bleeding, you can use INA to remove the heme. Intraoperatively, you can use viscoelastic. I prefer Helon GV or Helon 5, something that is going to tamponade the bleeding a little bit better. So that those are sort of my tips for how to deal with it intraoperatively. Postoperatively, there's not a whole lot you can do about significant hyphema. Obviously, if it's very significant, you can always take the patient back for an AC washout. I've never had to do that for a Cahook. But I think usually conservatively managing them like you would a traumatic hyphema with some steroids as you would use anyway postoperatively. You can consider doing some cycloplegia if it's causing a lot of irritation or discomfort for the patient. But generally, it does resolve pretty quickly postoperatively. Okay, so then this is one of my most popular procedures that I like to do, called the GAT, or gonioscopy assisted transluminal trabeculotomy. And so this is sort of similar to the canaloplasty, but as you can see, it's ab interno. And so in this procedure, we make an incision in the trabecular meshwork, and we thread the eye tract catheter 360 degrees around. We pull the distal end as well as the initial proximal end, and you can basically create a 360 trabeculotomy. And you can also use a 5-0 Prolene for those who don't have access to an eye tract catheter. But it becomes more difficult to know when the catheter has gone all the way around or has gone down a collector channel. So it's more challenging with the 5-0 Prolene, but it can be done. So the reason I like this procedure in particular is that you can lower the pressure substantially. So we'll discuss a few cases of that shortly. And so you can get a lot of effect with no implant and a relatively short recovery period. The downside of this procedure would be that you are pretty much guaranteed to have a large hyphema. Patients are often hand motions from the hyphema post-operatively. The first week or two can be very distressing to the patient, so you have to be able to warn them. Ideally, they're not monocular so that they would still have functional vision in their other eye while this is healing. But I also really like using this as my preferred procedure for primary congenital glaucoma as well. So what are some easier ways to kind of achieve something similar that's not as technically challenging as the GAT? So this device called the Omni 360, it does an ab interno viscocanaloplasty and goniotomy. And so the nice thing with this procedure is that the device is just one-handed, and you can basically extend the catheter into Schlemm's canal, inject viscoelastic, and then as you pull out, it'll create a goniotomy and you can treat approximately 180 degrees in each direction, then rotate and treat the other 180 degrees. So this is probably an easier way to achieve something similar to GAT. You won't get the full 360 degrees just because it's hard to open up the last bit of the angle as you're withdrawing the device, but it gets you relatively close to that. All right, so let's talk about when to use GAT. These are patients, as with all the angle-based procedures, who have open angles. I particularly like it for people who have secondary forms of open angle glaucoma, such as pseudoexfoliation, steroid-induced glaucomas, traumatic glaucoma pigmentary, anything where the problem is really at the level of the trabecular meshwork, or we think it is. It's also great for primary congenital and juvenile open angle glaucoma. So let's look at a few examples. So here's a case of a 78-year-old woman with a history of HSV keratitis and mild pseudoexfoliation syndrome. So she's got a lot of reasons for having a persistently elevated pressure. Her pressure was in the upper 20s, low 30s, and she was having difficulty with many, many glaucoma medications. She had an open angle in both eyes. You can see how many medications she was on. It was quite a lot. We performed a GAT, and by post-op month 5, her pressure remained very low, 7 to 11 millimeters of mercury, and she was able to be off of all of those pressure-lowering drops. So you can see that GAT is very, very effective in achieving lower pressures. Now, I would say this is a little bit lower than what I would expect. Most of the minimally invasive glaucoma surgeries can really only typically get you into the mid-teens. It's relatively rare for them to get you into the low teens. But in this case, the patient did have quite low pressures afterwards. And as you can see, there's a lot of medications that were able to be discontinued. Here's another case of a younger man, a 30-year-old with bilateral juvenile open angle glaucoma, high myopia, and anisometropia. So you can see he was so myopic, he wore a -21 diopter contact lens. He was on a couple medications. His pressure was elevated at 36. We ended up doing cataract surgery and GAT in the right eye. At post-op month 1, we were not very happy because his vision was only count fingers at pinhole to 2100. Preoperatively, he was 20/40, and you can see the pressure was 6, which is quite low. And when we looked on exam, he had a nasal choroidal effusion, and ultrasound biomicroscopy showed a 2-hour cyclodialysis cleft. So in this case, we encountered the problem where we actually created a cyclodialysis cleft. Sure, it lowered the pressure, but it lowered it so much that the patient ended up having vision loss from hypotony. So what do you do in these cases? So in this case, we attempted an argon laser treatment of the cyclodialysis cleft. So you can see these were the laser parameters we used. And these are a pretty hot laser, and we applied it diffusely to the sclera, the ciliary body, and iris deep within the cleft. So you're basically just trying to induce a lot of inflammation in the area of the cyclodialysis cleft. About 2 weeks later, he complained of severe eye pain, and his pressure was up to 45. So that's a good result if you're trying to close a cyclodialysis cleft. It can be very dramatic, so you need to warn the patient. If you have a sudden, pain, that usually means that we need to see you right away because the cleft has closed, and often in that setting, the pressure becomes very high. So the cleft did close with the laser. Thankfully, we put in a tube shunt because the pressure was very high, and his vision improved to 20/40, and his pressure remained in the low teens. As you may remember, it was 36 preoperatively, so we did get a good outcome. But this is an example of a case where he had an unexpected complication that made him worse off because he had reduced vision from hypotony, and ended up needing treatment for the cyclodialysis cleft, and ultimately a more traditional glaucoma surgery such as an Ahmed tube shunt, but did well. So cyclodialysis clefts can be quite challenging. They're beyond the scope of this discussion. I had another patient who underwent GAT for traumatic glaucoma, had a larger cyclodialysis cleft that would not close with laser, ended up having surgical closure of the cyclodialysis cleft. That evening, after the cyclodialysis cleft surgery, her pressure was 75. She was in severe pain. She ended up having trabeculectomy the next day, and has done well after 2 sequential blood needlings and is off of all her medications and is doing very well. So it can be pretty challenging to manage these complications. I would say just be ready for running into unexpected issues anytime you do even what we consider minimally invasive surgery. So some of the tips and tricks for this type of procedure, as I talked about, choosing viscoelastics that are more likely to tamponade the bleeding in the anterior chamber, doing a washout intraoperatively, the view becomes more limited. I always leave some viscoelastic in the eye for GAT, just because I know there's going to be a hyphema. There are positioning tricks to reduce the amount of bleeding through the angle. And then if you can't get all the way around the Schlemm's canal, you can inject viscoelastic and withdraw the catheter and do basically an ab interno visco canalostomy. Okay, so the next set of procedures I'll move through relatively quickly. So these are all conjunctival utilizing procedures that are variants on trabeculectomy, such as the express shunt here, which has become less popular because there are other options available. But in this procedure, you're essentially doing a trab, but rather than doing the punch, you're putting in the shunt, which gives more controlled flow, faster recovery of vision. The problem is you can't really needle the actual shunt. It can get clogged. They can get exposed over time. So there's no perfect procedure. The Zen gel stent was originally designed very similarly to be implanted ab interno. I would say most people are implanting them ab externo now with mitomycin. It can be very difficult to get the tip in the right position between conjunctiva and tenons, and there's a pretty high percentage of these patients who need postoperative blood needling. So it's important to let the patients know that they will likely need to have blood needling postoperatively in these cases. One of the newer types of procedures here is the PreserFlow microshunt, which uses a special material like the Zen gel stent. It really relies on having this very tiny lumen for restriction of flow. You also still need to inject subconjunctival mitomycin and also do postoperative blood needling. So there's no 100% guaranteed single surgical procedure that is going to get you exactly the outcome you want every time. Now I'd like to talk about some of the ciliary body procedures. So this is the micropulse transscleral cyclophotocoagulation. You make sweeping applications over the limbus targeting the ciliary body. It is uncomfortable, so you do need to do a retrobulbar block. There's less post-op inflammation compared to traditional CPC, and that's because the laser is basically on and off alternatingly, and so you're delivering less energy over time compared to a traditional laser. So this is sort of the nice things are that it's not incisional, so the risk of infection is quite low. But again, because you're delivering less energy, the benefit is also lower than doing a traditional CPC. Endocyclophotocoagulation, this is intraocular surgery. You have a probe that goes inside the eye. You directly visualize and target the tips of the ciliary epithelium, and it's quite a lot of fun, very enjoyable to do because you can see them shrink and whiten in real time. And you can also perform them pars plana, which I sometimes do with neovascular glaucoma that has been very difficult to manage in conjunction with my retina colleagues. If they're doing a pars plana vitrectomy anyway, you can paint the entire ciliary body, the entire processes, even in the posterior chamber, when you're going from the pars plana. I also like to use this in patients who have failed tube shunt surgery. So if their pressures are high, they've already had a tube, rather than putting in a second tube, which increases their risk of corneal decompensation, I often will do an ECP as sort of my next step. The patients do have to be pseudophakic, so that is a limitation. All right, so to kind of summarize our discussion today, it's really important to match the surgery that you choose to the type and severity of glaucoma that the patient has. You want to think about, what is my target pressure? If you need a super low pressure, let's say you have somebody who's progressing and their pressure is always 12, probably they would need a trabeculectomy. It's very unlikely for a minimally invasive glaucoma surgery to really achieve pressures that low. And you also have to consider the risk of complications. Older patients, those who are on blood thinners, those who've had multiple prior surgeries or have a lot of difficulty with following up, you might want to pick surgeries that have a lower risk of complication. All right, so let's go back to case one. And this kind of goes back to the question that has been posed here about losing an eye stent intraoperatively. So it's really common to, when you try to inject an eye stent, that you don't quite get it in the right position, and now it's just floating in the anterior chamber. And so you can recapture it with the injector device. If you can't find it, sometimes, using the INA, you can clear the heme to be able to visualize it better. Sometimes you just won't find it and have to assume that it got washed out somewhere. But yes, you can reimplant it if you are able to retrieve it. It's usually easiest to retrieve it and get it back in position inside the eye with the viscoelastic. It's relatively more difficult to try to take it out of the eye and then try to physically hold it with some instrument and get it back onto the injector. So in general, it's better to try to get it repositioned on the injector device while it's still in the eye. All right, so back to our case. This was actually case two. And so this monocular man, I forgot to tell you that he had a history of idiopathic vitreous hemorrhage. So even though this patient was not on anticoagulation, he actually had a pretty significant risk factor for bleeding, which is that he bleeds spontaneously, and we don't really know the reason for that. He had the visually significant cataract. He was only on one medication. His angle was open, and so he seemed like he would be a candidate for cataract with eye stent. However, he ended up, as you saw in the video, with lots of heme intraoperatively, and he ended up with a total hyphema, and this was his only seeing eye. Because of that, he ended up having to be admitted to the hospital because he lives alone. And with the total hyphema, he ended up having high pressures that could not be managed medically by post-op week 1. He had to go back to the OR for an anterior chamber washout. Fortunately, that did improve the vision. His pressure was controlled afterwards, and he was discharged home with no further complications. So where did the eye stent go? It actually was found deep in the angle, and you can see it on the ultrasound biomicroscopy that there's a metallic echo there. It just got buried quite deep. And so it seemed like he still got the effect he wanted, but I think the complications, even though his visual outcome was good, it took a lot. It was unfortunate given how elderly he was and the fact that he had to be admitted and have additional surgery for the anterior chamber washout. All right, so to summarize, basically we've talked about a variety of different minimally invasive cataract surgeries. This case that we talked about with this 90-year-old man, generally the safety profile of combined cataract with eye stent or any other MIGS procedure is generally pretty good. Hyphema can happen, but is usually pretty limited, unlike in the case that I showed. And so it's relatively rare to require an anterior chamber washout. Anytime you're taking care of people who are very elderly, who have prior history of bleeding that's unexplained, or the view is very poor for some reason, you have to wonder, is this a good choice to do minimally invasive glaucoma surgery, especially if you're working in the angle where the view is really critical. You have to keep in mind that even if you're doing a low-risk procedure, if you've chosen a high-risk patient, that doesn't make it a low-risk procedure anymore. So anytime you're operating on somebody who is a high-risk patient for a variety of reasons, that makes it a high-risk procedure. And so As Shakespeare told us, discretion is the better part of valor and caution is preferable. So choosing not to do surgery or choosing to stop the surgery when things are not looking well is usually the best choice. It can be hard for some of us surgeons to stop because we're so focused on our goal, but it does take a lot of self-control and maturity to be able to recognize when you're in a bad situation and you don't want to make things worse. People often say, better is the enemy of good. All right, so just to give you some visuals, low risk surgery, you can think about glaucoma surgery like this dentist here. If some of our traditional glaucoma surgeries might seem higher risk, some of these minimally invasive glaucoma surgeries might seem a little lower risk, almost like, just brushing your teeth. But if you're trying to do a low risk procedure on a high risk patient like this line here, you're probably asking for trouble. All right, so with that, thank you so much for your attention. I'd like to thank these folks who helped contribute to this presentation, and I'm happy to answer questions. So I'll just start with the top one. What do you foresee as the next frontier beyond MIGS and glaucoma management? So I don't really see this as sort of well, I guess you can think about the paradigm of how we manage glaucoma shifting. So a lot of people have advocated that we treat glaucoma initially with laser, so selective laser trabeculoplasty or SLT. The results of the LIGHT trial from the UK have shown that you're more likely to prevent visual field progression. You're in patients who are treated initially with the laser and rather than starting medications. And so the way that a lot of people are thinking about how we treat glaucoma in the future will be really starting with laser therapy and then eventually transitioning them to cataract surgery with MIGS. And really trying to minimize the amount of time that patients are using medications. I think that really can be helpful because we know medication adherence is so challenging, even in countries where we have all the resources, and particularly in low and medium income countries where supply chain issues mean that patients have a very limited selection of medications they can use. They might have a hard time obtaining the medications from the pharmacy on a regular basis. They may have trouble keeping the medications in controlled temperatures that keep them from going bad. So I think there's a lot of utility in trying to avoid medications and really minimize the need for medications in the future. And that's sort of really the paradigm shift that I think a lot of people are moving towards in terms of how we manage glaucoma. The next question is, what surgery would you prefer in a patient with controlled uveitis? So it depends. People with uveitis can either have an open angle or they can have a closed angle from PAS, peripheral anterior synechiae. And so if the angle is open, then we have lots of great options, as I was discussing earlier, for all of the angle-based surgeries. And so really depending on the degree of pressure lowering you need, I think any of the angle-based surgeries would be reasonable if the angle is open. If the angle is closed with PAS, then it really kind of limits your options. Typically, I would do a tube shunt in those patients just because even if it's well controlled, they can have recurrence of their uveitis, which makes trabeculectomy more difficult to sustain long term. And I try to avoid ciliary body procedures just because they tend to be more inflammatory. So then the next question here is, when you do ECP, how many degrees do you treat? I typically, when I do ECP, I'm doing it as a standalone procedure, usually in patients who have already failed a tube shunt. So I typically treat 360 degrees. And so what that means is that I have to make 2 incisions, one temporally, which is the traditional way, and then one nasally. So I actually have to change position where I'm actually on both sides of the patient and can treat all 360 degrees. The next question is, in countries where the eye tract catheter is not accessible due to the cost, a modified GAT with 5-O-proline is also effective. Yes, I did mention that. I have used the 5-O-proline. In terms of as I mentioned earlier, it's a little bit more difficult to visualize if you go down an aqueous collector channel. What I like to do is I like to take a high temp cautery and just hold it close to the tip of the 5-O-proline. What that does is it melts the tip of the 5-O-proline and it creates almost like a mushroom cap appearance. And what's nice about that is it means that the proline is less sharp, so it's less likely to go down a false channel as you're moving it forward. The other nice thing is if your proline gets stuck, meaning you can't advance it any further, and you start pulling it out of the eye, sometimes the mushroom cap will actually just tear the tissue as you pull it back. And so you're still getting the benefit of the GAT anyway. So that would be my pearl for using the 5-O-proline. I also use the 5-O-proline in cases where the eye tract catheter, we opened it, it got damaged somehow. Maybe we got stuck and we kinked the eye tract catheter and it's not able to be advanced anymore. Fortunately, I've had some good experience lately in unkinking it just by crimping it with a tire to try to straighten it out. But that's why sometimes I end up using the 5-O-proline if needed. The next question is about bent ab internal needle goniotomy. I would say it's pretty similar to the Cahook. It's cheaper, obviously. I think the goal of the Cahook is to really remove an entire segment of tissue, whereas doing a bent needle or just a traditional needle goniotomy, as we normally would do for pediatric patients, it's more likely to close. But I would say it's pretty similar to the Cahook in terms of complications. What is your experience regarding Zen shunts for secondary glaucoma? Is there a higher failure rate or common need for further surgery? So I personally do not perform the Zen gel stent, but I would say that it's typically reserved for patients who have not had prior conjunctival surgery because it really relies on having that really beautiful conj superiorly. I think I would be reluctant to use it for patients who have recurrent uveitis just because there's greater risk of fibrosis over the bleb. I think pseudoexfoliation would be a reasonable choice for doing a Zen shunt, although I'd probably favor doing angle-based surgery first. The next question is, could we perform transscleral cyclophotocoagulation in patients with relatively good visual acuity but poor visual fields? So there have been more studies lately of people doing transscleral CPC in patients with 20/20 vision, and it works. I would say the problem is you're still getting a lot of postoperative inflammation. Sometimes people will get macular edema. I really try to avoid transscleral CPC in children just because you can get a lot of inflammation. I've seen pediatric patients develop macular ischemia, so it's not, it can be done, especially in patients who perhaps you're worried about follow-up or maybe less reliable about taking postoperative medications, so you don't want to do incisional surgery. So it does work. I would just say the risks of having a poor visual outcome related to inflammation may be higher. But it is doable. I just think that there are usually better options. Okay, so the next question is, how do you know when you've had a successful transscleral cyclophotocoagulation procedure? With transscleral CPC, I typically do them in patients who have poor vision, just because it's so inflammatory. And if they had better vision, I probably would be doing a tube shunt or trabeculectomy for needing really low pressures. So I would say my average transscleral CPC patient is probably somebody with like end-stage neovascular glaucoma who has maybe light perception or hand motions vision. They're on a lot of medications, including Diamox. Their pressure is still very high. They may be in significant pain. And so my main goal is to get them off of most of the medications, especially the Diamox pills, because those can create a lot of side effects, and to achieve a pressure that's reasonable. Some people try to get a pressure within the normal range for those patients. Others just try to get them to a point where the eye is comfortable. Many of those eyes are quite sick, and so as long as they're not in pain, then that's sort of the threshold that you titrate to, even if the pressure is seemingly high and you know that they may eventually lose all of the remaining vision. I typically will do transcleral CPC only in patients who have significant vision loss already. Well, I hope as a result of our talk today that more of you will begin trying minimally invasive glaucoma surgeries, since it seems like the majority have not done any minimally invasive glaucoma surgery. As I said, often the easiest ones to start with are the angle-based procedures, and you can practice your intraoperative gonioscopy even in your cataract patients so that you can practice getting them into position with a good view, moving a viscoelastic catheter around the anterior chamber angle, to be able to allow yourself to manipulate inside the eye without disrupting your view, and being able to pivot within the wound with that instrument. And I wish you all the success in moving forward with minimally invasive glaucoma surgeries. Just remember, as a glaucoma surgeon, we all have complications. You're never alone. And there are plenty of options, including traditional glaucoma surgery as the next steps if needed. I'm seeing a few more questions in the chat here. If a patient after iStent implementation, I think your question is hypotony, how do you manage that? That would be pretty unusual to have hypotony after iStent implantation. I would say that I would look for a cyclodialysis cleft. In that situation, oftentimes patients can be managed conservatively with atropine. Some people in that case will just not use any steroids postoperatively in the hopes that the inflammation will help close the cleft. And you can always try lasering the cleft using a UBM to identify the location of the cleft. And often, and hopefully you won't need to do this, but surgical closure of the cyclodialysis cleft is also possible. The differences in patient selection between iStent and Hydrus, it's really, I would say the iStent, you're going to get a much more limited effect than the Hydrus. So if you really need a lot of pressure lowering, or the patient's on 3 or 4 classes of medications, probably the Hydrus would be more likely to achieve the result that you're looking for, but it would be more difficult for the surgeon, especially those who are newer to minimally invasive glaucoma surgery. All right, well, I think we're at the end of our time. Thank you again, everyone who participated. I'm just delighted that we were able to engage so many colleagues from all over the world, and I wish you all the best in your management of glaucoma patients, and we'll see you next time. Thanks.